NIPE or NIPE. I never know how to pronounce it. I think I most probably will be saying NIPE because of my Spanish background. Anyway, there we go. Okay, so autonomic nervous system is like the ugly duckling of neonatology. Is always far more popular to say that you're going to talk about respiratory, LISA, surfactant treatment, non-invasive ventilation, the patent ductus arteriosus, something like that is always a lot more fancy than saying, I'm going to talk about ANS. Is not that popular within neonatology, which obviously means that is something we have to correct because the autonomous nervous system is involved in all these organs that I've already said, the lung, the gut, the heart, is the management of all these organs. To some extent, it relies on the autonomous nervous system. In fact, except the gut, the rest of the organs, they all have like a baseline activity managed by the sympathetic nervous system. And the parasympathetic works a little bit like modulating that activity, right? In the gut is exactly the opposite. The parasympathetic which gives you the baseline activity, and the sympathetic is the one that modulates the activity of the parasympathetic. So it is very important. We have been taught in medical school that these three pictures, when we are at rest, that sympathetic baseline activity is modulated by the parasympathetic, and it reduces its activity and makes you more, your heart rate goes down, your respiratory rate goes down, and everything is calm and cool. If you're in a stressful situation, then that parasympathetic is going to modulate a lot less, and it's going to let the sympathetic take control, and your heart rate will speed up, your respiratory rate, you'll get sweaty hands and all these things. And when you are on a fight or flight situation, then here is not only that the parasympathetic does not do any modulating activity, but the sympathetic is going to even increase its activity and take control. If a lion comes into the room, sympathetic takes control, and your heart rate will go really fast, and a fight or flight situation. That's what we've been told. I can tell you that is not always like this. I mean, there is we should do another talk about the pathologies that the autonomous nervous system can have. There's a phenomenon called co-activation, where the sympathetic and the parasympathetic can activate both at the same time, and therefore you have an abnormal response to a stressful situation. But let's stick to what we know, and let's don't make things more complicated. But what we've been told is that there is a synchrony, there's harmony. If the sympathetic goes up, the parasympathetic goes down, and the other way around, right? And that is in most of the cases it is like that, right? And if we want to measure, we want to know. We want to measure the activity of the parasympathetic or the sympathetic. We have these two tools. To measure parasympathetic, we have heart rate variability, and to measure sympathetic nervous system activity, we have the skin conductance response. Today, I'm going to focus on the heart rate variability. And how does it work? Well, if we think about the respiratory sinus arrhythmia, what we have is, as we've said before, we have the sympathetic taking control of the heartbeats, right? And the sympathetic and the parasympathetic acts as a brake, right, and slows down the activity. So when we breathe in, the heart rate goes a little bit faster, or the QRS complexes come together, And when the air goes out, they get a bigger distance between them. And that variability on the QRS is what we use to measure how much time do we have from the R of the QRS complex in each beat. And we measure those milliseconds, right? So when you're taking a breath in, you can measure, 845 milliseconds in this example, and when you breathe out, it's about 870 milliseconds, right? With this variation, this variability, if we put it on a graph, we can see that there is a very low frequency variation, and that very low frequency is from 0.004 to 0.04 hertz. That one is regulated mainly by thermoregulation and the endocrine system. The low frequency heart rate variability, it's modulated by sympathetic and parasympathetic. But the high frequency, the one that we are very interested, is mainly modulated just by the parasympathetic. So these machines, what they focus is on the high frequency heart rate variability. So in that way, you can measure pure parasympathetic activity. And this is the machine that we're talking about. So yeah, newborn-infant parasympathetic evaluation. So this measures parasympathetic evaluation, right? Well, plenty of people who've never heard about this machine may think right now is, well, fantastic. Okay, we have a pain monitor. And I'm afraid that that's not exactly that. Are we measuring pain or are we measuring stress, comfort? Well, let's talk a little bit about pain, and we'll try to find out differences between pain and stress. According to the International Association for the Study of Pain, pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So the key points on when we are talking about the definition of pain is these three are extremely important. Pain is always a personal experience that is influenced by biological, psychological, and social factors. So it's not something that is going to be easily measured. Pain and nociception are not the same. Nociception is the activity from the sensory neurons, and pain, as we are seeing in these definitions, it involves many other things. And the third problem we have as neonatologists is that our patients don't speak and don't verbalize the pain they have. That doesn't mean, obviously, that doesn't mean that they're not experiencing pain, but that gives difficulties to measure or to acknowledge the amount of pain they're in. And what we've been using in our neonatal units to evaluate the pain of our babies is pain scales, right? I've put a few here, but I can tell you there are quite a few more, which already tells us that there's no magical pain scale that is fantastic and better than the other ones. Just by the fact that there are so many and they keep coming up means that it's very difficult to get the right one. And why? Well, these pain scales, they are taking into account different parameters, from heart rate, saturation, respiratory rate. So physiological changes are some of the parameters that tend to be in all these scales, but others like behavioral responses. If the baby is crying, grunting, or if the baby makes facial expressions, all these, and some of them even Some of them even include some hormonal responses like cortisol. So it's quite difficult to do a pain scale that works, mainly because there is no gold standard. There's no gold standard to measure pain. So there are many different attempts to find a way to measure pain, to incorporate that variable in our care in the neonatal units. So what problems do we have with pain scales? Where there is a motor component, right? The motor component that we can evaluate in different scales. Obviously, it's going to be influenced by the gestational age of the baby. The motor reaction to pain of a 24-weeker or a term baby is going to be completely different. These babies plenty of times have respiratory support and have a bit of sedation. So the responses are going to be influenced by differently in different situations. The other problem is that you can't just take a scale and start using it. You need to train your staff. You need to have experience using that a scale to be able to use it appropriately. And the other problem is that we are taking a photograph. So if we pass a pain scale to a baby, we'll know exactly in that moment what pain score is going to have. But an hour later, we'll have to take another photograph. So it's not a monitor that gives you a continuous measurement of the situation. And on top of that, if we take into account that we are dealing with preterm babies and term babies, and the autonomic nervous system matures along these weeks, and the maturation in a 24-weeker and a term baby is not going to be the same, and therefore the response and the reaction of these ANS is not going to be the same. And the last problem is that acute versus chronic pain is completely different. Not only different, but we are going to manage it completely differently. So we're faced with many difficulties to measure pain, and basically it's because pain is far more complex than it seems. And we know by this classical study from Carvajal, the EpiPain, that our babies are exposed to an incredible amount of pain and or stress every single day. Things like, we may not be intubating every day a baby, but we are removing skin adhesives, we're doing heel pricks, we're doing many things that are very stressful. So we need to do something and try to know what things are more stressful or less, and so we can take action to decrease them. And if we go back to this machine, I'll explain a little bit how it works. So we have, I don't know if you can see my pointer, but what we have is a signal that the machine, measuring that heart rate variability, it gives you a percentage, right? So 0 would be pure sympathetic activity, and 100 would be pure parasympathetic activity, more or less. Okay, if we think or remember that synchrony, that harmony we were talking about, that means that if we are above 50, we will be having more parasympathetic than sympathetic activity, right? Okay, so when we put this monitor in a baby, one of the things that I really like about it is that you connect this monitor to the constant monitor of the baby. So you don't connect it to the baby, you don't put anything. It just extracts the heart rate trace from the normal monitor and it translates it into NIPE, right? So we have when we put it in a baby, we have a baseline, and as soon as there is a stressful event, it drops down. So it predominates the sympathetic activity. When you stop that stressful event, it will come back up to that baseline, right? Okay, so we see in our babies many stressful situations. Yes, we've been talking about pain, but uncomfortable position, hunger, light, noise, feeding. Why do I put feeding there? Well, feeding, it's a stressful situation for the autonomic nervous system. Although we think, if you think of about a newborn in her mother's arms, giving breast milk, that is like the iconic or most comfortable thing we can think a baby could be. Well, in reality, at that point, that baby, if it's a late preterm, for instance, is a baby that is starting to coordinate suction, swallowing, and breathing without mixing all it up. So all those are managed by the autonomic nervous system, and we are stressing that situation. So that means that here, where it says stressful event, we could put breastfeed, and it will go down and then up again. And this response to a stressful situation will become better as the baby grows and perfectionates its coordination of these three things. And that means that this drop going down, it will be less pronounced the more the baby matures and coordinates better. So let me give you a real example, right? This is a study we started, and this is one of the first babies we started this study, and what we were trying to see was the analgesic effect of saccharose, breast milk, or placebo measured by the NIPE, right? And as we can see here, right, we had a baseline above 60. We gave a couple of minutes before the stressful event, we gave saccharose, and it did go up a little bit. We put the NG tube, that was the stressful event, and it dropped down and then slowly started to recover, right? Okay, this was one of the first babies, and it was one of the first babies we were using this machine, this quite a few years ago. And we were all excited here, just looking at, oh, look, it's gone up, it's gone down, it's just about 10%. And we were all excited. And the nurse that was caring after the baby said, excuse me, have you finished with the experiment? Can I carry on with, oh, yes, please do. Look after the baby. And then this is what happened. We were just looking if, from 60 had to gone up to 70 and then down to 50. And then all of a sudden it went up above 90. And we thought, oh, something's wrong with the machine. What's happened here? And we look at the baby, and what the nurse had done after the experiment was putting the baby in kangaroo care with his mother. And then all of a sudden, all these went up there. So we are measuring stress and comfort, which means, yes, a stressful situation like introducing an NG tube is going to cause stress. Yes. But there are many things that we're doing in our neonatal units that cause comfort to these babies, and we have to be very aware of it, as we'll see in the following studies. So, what do we have to evaluate comfort in the NICU? Well, in this study done 10 years ago, 10 infants with a mean gestational age of 33 weeks, they evaluated NIPE from 10 minutes before till 10 minutes after the experiment. And what they did was tucking, or cocooning in French, tucking these babies, and either the mother or a nurse read for 5 minutes while this baby was tucked, right? They measured before, after, and you can see here that the NIPE went up in all the cases. Every single case went up. on average from 55 to 69, so it's statistically significant, and there was an improvement just by tucking the baby and reading to the baby. This was when the nurse read, and this was when the mother read. So in both of them, there was a significant increase in NIPE, right? But interestingly enough, there was no difference when you compare mother and nurse. It made no difference. So I don't know if the tucking was more important than the voice, or before anybody asks, I don't know how many hours that mother was spending with the baby, or if it was enough to recognize its voice. I don't know. But human voice and tucking, it improves the parasympathetic modulation of the sympathetic activity, right? Let's see another example. Right, in this one, what they did was in 22 babies with a median gestational age of 27 weeks, they simultaneously measured NIPE and ANI during skin-to-skin contact. ANI is the big brother of NIPE. Well, in fact, it's the other way around. NIPE is the newborn version of ANI, so it measures exactly the same in children and adults, right? So what they did was they monitored the parasympathetic activity of the mother and the child, right? 30 minutes before and 30 minutes after skin-to-skin care. And what did they find? Very interesting, because the mothers, all of them significantly, very significantly, increased their parasympathetic activity from 70 to 80 and then down again to 75. So skin-to-skin contact was very good for the mothers. It relaxed them a lot. And in the children, in the newborns, was very interesting, because they found that using a threshold of 57, they found differences. So in all of them, there was no difference. But what they found is that if their baseline was below 57, then there was a significant increase, not 0.0, right? So from 51 to 55 and 51, right? But if the baby's baseline was above 57, that, believe me, that is very good parasympathetic activity. The baby is very relaxed. Then it didn't have any response. So it increases when it's low, but when it's high, it doesn't increase it anymore. These are just examples, but there's more examples on the literature, looking at all the things that we are doing in individualized family-centered developmental care. So cocooning, skin-to-skin, kangaroo, all of them. There are several studies just seeing that the NIPE goes up when we do these things. So in a way, this machine is helping us validate all those procedures that we believe that are good for the babies. And okay, so that's very good to measure comfort, but can we monitor pain in the newborn? Because, you know, we all want to find a pain monitor. As I said, this is not a pain monitor, but what we can do is in a control situation like in surgery, in theater, what you can do is when you can evaluate nociception during surgery under general anesthesia. So what is happening here? What's happening here is that, as I said, there are many different variables involved in pain, right? When we anesthetize somebody, we're taking away many of these ones, like hunger, noise, light, all these. When the baby is anesthetized, we're eliminating it from the equation, and we are relying the pain more on the autonomic nervous system. So measuring nociception at this point can be very helpful. And there are a couple of studies I want to show you. This one is a prospective observational study, and they made two groups of patients, right? The first group was healthy children from a pediatric ward, And the second group were critically ill, deeply sedated and ventilated preterms and neonates from the NICU. Right. All of them were under general anesthesia to have surgery performed. Right. And being on general anesthesia, they measured NIPE and heart rate before, during, and after 3 nociception events that they chose: venous puncture, intubation, and skin incision. So I want to remind you that anesthetists in theater for many years, they've been using heart rate to titrate the dose of analgesia, or to see if the baby is stressed or not, right? So in these babies, what they found is, here on the left, we're going to evaluate the heart rate first, right? And here, what we can see is that with the venous puncture, intubation, and skin incision, before and after, so that's the heart rate before and after the stressful event, right? As you can see here goes a little bit up, here goes a little bit down, and here stays more or less the same. That's in group 1. In group 2, they could only evaluate the skin incision, because I remind you that they were babies that were already intubated from the neonatal unit and heavily sedated, so they could only evaluate skin incision. And what they found is that there was no correspondence in the heart rate response to the event. As you can see, the P's here, 0.5 or even 1. So there was no organized response. Heart rate response was to evaluate pain. But when you see NIPE, you can see before and after, the NIPE goes down. With the event, it goes down. With the venous puncture, is not statistically significant, right? But the rest is all the intubation, skin incision, and the skin incision in the second group is very well correlated. Even more, if we look, the NIPE index decreased in 91% of the recorded events. The heart rate increased in 38% and decreased in 53%. So yes, in intubation, we all know that you can have bradycardia, you can have tachycardia. So using the heart rate to evaluate pain or nociception in these babies is inferior to using NIPE. And if you see the ROC curve, and the R under the curve is 0.9, 0.9, 0.9 for NIPE, and for heart rate is 0.57. So it's better NIPE than heart rate. There are several studies looking at NIPE during general anesthesia, but we have to remember that we are neonatologists, and neonatologists, we deal with preterm babies as well. And as I was saying before, the maturation of the ANS is extremely important. In this study, what they did is they measured the heart rate variability in fetuses. So before they were born, this first column here is the end of the second trimester, the beginning of the third, and the end of the third trimester. And we can see here the parasympathetic activity, that it increases in those all through the gestation, right? So what this group of investigators did is, right, if we can see this in the fetus before the baby is born, we can see that the parasympathetic activity is maturing all through the end of the second and all through the third trimester. If we measure the parasympathetic activity in the first days of life at different gestational ages, we will have a very similar graph. And so that means that what we're measuring is the baseline, right? So in a 24-weeker, the baseline would be very low, and a term baby would be higher, right? Okay, what they found was not that at all. What they found is that 25, 26 to 31, you can see here the values 0.4, 4, 3, 2, 1, 1, and a term baby scored 162. So that means that when these babies are born, they're all extremely low compared to, so there's no, there should be like a line like that going up, and lower in the 25th and higher in the 30th, but they're all extremely low. And the most worrying thing is not only that, is the fact that when you see in post natal corrected ages, you can see here the black dots is where the babies are born, and the line is the corrected gestational age. So if up here is a term baby when he's born, we should be seeing lines going that way if the parasympathetic activity would be growing healthily in these babies as it does in a fetus that is inside the womb of the mother. So what does this mean? This means that these babies are exposed to an amount of stress all through their stay in the neonatal unit that their parasympathetic activity is not having a chance to attenuate that sympathetic activity. And it's very, very worrying how these babies are going to evolve in the future. I want to think that all this is because this study was done in 2007, and if we repeat this study today with what we know about stress, things would be a lot better. So this is how a baby looked in 2007, and I insist, I want to think that today the results will be a lot different. So just to start closing this talk, I'd like to give you a few take-home messages. Well, first of all, I'll say it again, NIPE measures parasympathetic activity. So that is not a limitation, in my view. I think that is an opportunity, because there's many other things you can measure, not only pain. NIPE is not a pain monitor. Pain is far too complex to be measured by just one variable. NIPE is very good measuring long-term discomfort, and is a good tool to evaluate fee care effectiveness. NIPE is very good measuring nociceptive stimuli. It's used in anesthetized newborns, and infants its use in anesthetized newborns and infants looks very promising. But I want to take a bit of homework as well for any of you that is interested in doing research. We need more papers on NIPE. We need to improve our knowledge on autonomic nervous system in term and preterm babies. We know very little, and we know very little and on how it matures and how it affects in the care of the baby and in the reaction or response to a stressful situation. We need to improve our knowledge on pain as well in term and preterm babies. It's extremely difficult matter to manage if we don't have tools to measure. If we think about the comfort and discomfort, we need more research in thresholds, response times at different gestational ages. And the anesthetists are now very interested in using NIPE in theater. And there are many questions to be solved yet. NIPE and propofol, NIPE during apnea time, because if it measures heart rate variability and we are inducing apnea, what's happening there? how it responds to different antinociceptive therapies, interference with vasoactive drugs, and what's the effect of titrating NIPE in the post-op pain. Opioid titration intervals. When do you have to reduce or increase the opioid dose according to whatever value the NIPE is doing? So there's many things we can research, and I think it's a field that is very much worth investing some time. And with this, I'd like to finish this talk, and I'll be open to questions, comments, and anything you want. Thank you.
So thank you very much, Dr. Boix. It was a really great lecture from your side. And now maybe there will be some doctors that would like to make some questions.
Maybe there's somebody using it as well. I want to share comments on how do they use it. I can tell you how I use it on an everyday basis. We use it to many things, from babies with bronchopulmonary dysplasia that are requiring respiratory support, non-invasive respiratory support, to titrate how comfortable these babies are is extremely useful. You can see from far away if the baby is uncomfortable and needs a change on the CPAP because it's been dislodged and the baby is uncomfortable. You can see it very, very, very well. We've used it to evaluate how babies late preterms that are starting to feed and are not very good at all to coordinate and have difficulties in learning how to feed. It's very useful to see how they respond, and plenty of times with the instant NIPE you can even stop the feed and let the baby recover and then carry on.
Mm-hmm.
There are plenty of situations.
Yeah, as well, maybe with physiotherapists too. I don't know, Dr. Boix, if you had some experience with respiratory physiotherapist in neonate care.
We don't put the monitor on these babies. I will try, but normally the problem is that we'll try. I mean, normally we haven't used it because of the interference, because when you're doing physiotherapy, the heart rate signal goes up and down, and it's difficult to get a reading. But yeah, I think in Poland
there are some hospitals already doing that, and it might be, well, you know that NIPE is based on heart rate variability, so it is assessing autonomic nervous system, as you have said, very good. So our autonomic nervous system might be stressed during the actions that the physiotherapist is doing. And there might be a moment in which we are really tiring too much the baby, and that might be seen in the device. So it might be like a call of attention that we should stop the therapy in those moments.
Absolutely, yes. In fact, it's any stressful situation for the baby. Well, to have a monitor that tells you if the baby is getting tired or if you're going too far with feeding is very good. You can see it straight away.
Mm-hmm. And do you have any experience with high frequency ventilation?
Yes, and at the end the main problems would be signal. you can get very bad signal in heart rates. So if you get the interference of the high frequency oscillation on the heart rate, then you can't measure anything. But it's very interesting with high frequency oscillation, because we've been moving clinically from, if the baby is in HFO, you have to have him sedating, and it's not good that the baby is breathing on top of the high frequency oscillation. That's what we used to do at the very beginning. We see that that's not true, that the baby can be very comfortable and can be breathing on top of the high frequency without a problem at all. And that is confirmed with NIPE. You get surprises as well. A baby that is on high frequency oscillation, and you think that is going to be in a lot of distress and you're going to need a lot of sedation, and you put the monitor and they're not uncomfortable.
That's very interesting. Yeah,
that doesn't happen with all of them.
Of course.
Hello,
So is there any
one question? Sorry.
Yeah, go ahead, please.
Hi, my name is Dorota Bursiewicz. I'm from Poland, and we use NIPE, but for now only when we want to check if there is some post-operative pain and so on. But I want to ask if you can manage the need of sedation and maybe to reduce the sedation as using the NIPE or not. Maybe how is your opinion? Can I ask?
Yes, you can. But you have to bear in mind that NIPE is a parasympathetic monitor. It's not measuring pain, right? So you gotta be aware that it depends on how sedated is this baby, right? But you are gonna have ups and downs for other things rather than pain. So you gotta be. My advice always is, if a baby has the monitor on, and that baseline drops down, right? Think about all the possibilities it could have, right? It's not only pain that is going to make it go down, right? So think of other things. If the baby's hungry or something like that, it will bring it down as well. So, but if you're talking about a post-op baby that is intubated, sedated, and you want to titrate the dose, yes, you can.
Yeah, I think, in my opinion, of course, post-operative babies are the easiest one. I think we have most problem with those babies who are a lot of time on sedation, and you have to check if there's maybe too much or maybe too little sedation from them exactly. So maybe the changes in time can change our view of these children. I don't know. I'm only asking and I'm thinking about it, but I have no experience on that.
Well, if a baby is heavily sedated, that means that as I said before, you've taken out of the equation hunger, noise, light, all that.
Things,
all those things don't matter. So there you're going to be able to titrate the dose of sedation better, or the analgesia better. Sorry. But if we're talking about a baby who is very awake with a little bit of sedation, that is hungry, eats, feeds, has a CPAP, then you've got so many variables that could bring that line down, that you gotta check everything and make sure that
exactly.
But the main
that's why it's so difficult, really, for me.
Well, but to me, that is what is really interesting, because what the machine is reading is true. I mean, that parasympathetic is gone down, and you have to find out why, right? Because it may not be pain, but maybe that the baby is uncomfortable or is hungry, or there is a reason for it. So you got to look for it.
Yeah. Thank you so much, really.
Thank you.
Any other question from the assistants? So I would say that we are almost done. I want to thank you again to all of you for joining during this afternoon. And thank you very much for this excellent talk about the importance of the autonomic nervous system and how to measure with NIPE. You know, and remember that it's all about the autonomic nervous system balance. It's not only about pain, it's about comfort and lack of comfort. So thank you again to all of you, and wish you a very good afternoon.
Thank you.
Thanks a lot.
Thanks. Have a nice evening.
Thank you.
Bye bye.
Thank you so much.